Hello everyone, my name is Eric Chow from the Melbourne City Health Centre in Australia. Today I'm going to present the finding of the OMGEA trial, which was a double-blind randomized controlled trial of antiseptic mouthwash for gonorrhea prevention. The OMGEA trial was funded by the Australian National Health and Medical Research Council. The incidence of gonorrhea has increased sharply in many countries over the past decade. Also, there has been a rise in antimicrobial resistance in Neisseria gonorrhea, which has become an urgent threat to public health. Therefore, there is an urgent need for innovative strategy to address gonorrhea epidemic. Recently, it has been proposed that the oropharynx may be a key source of transmission of gonorrhea, either directly or indirectly through exposure to saliva during sex. And this includes kissing, grooming, or oral sex. If this is true, then gonorrhea control could be improved through intervention that target the oropharynx. We have previously conducted a GONE study which include an in vitro study and an RCT. The in vitro study showed that Listerine mouthwash at dilution of up to 1:4 for 1 minute results in a significant reduction of total Neisseria gonorrhea count. We've also conducted a small RCT of 58 MSM with untreated oropharyngeal gonorrhea. We randomized them to either use Listerine or saline, and we asked them to rinse and gargle the solution for 60 seconds. The bar chart on the right showed that men in the Listerine group have a significantly lower positivity in the oropharynx by culture compared to men who use saline. This result suggests that antiseptic mouthwash could potentially prevent oropharyngeal gonorrhea. And therefore, we conduct the OMGEA trial, which stands for oral mouthwash used to eradicate gonorrhea. The trial aimed to determine whether daily use of mouthwash that inhibits the growth of Neisseria gonorrhea in vitro will reduce the acquisition of oropharyngeal gonorrhea compared with a mouthwash that did not inhibit the growth of Neisseria gonorrhea. The trial was conducted between March 2016 and October 2018. It was a multi-center double-blind RCT in Australia across 3 sexual health clinics and 1 GP clinic, with a total of 530 MSM recruited. The primary outcome was the detection of oropharyngeal gonorrhea by NET, and the secondary outcomes include the detection of oropharyngeal gonorrhea by culture and also site-specific gonorrhea and chlamydia diagnosis, as well as syphilis and HIV. In order to be eligible, men need to be aged 16 to 24 years because this age group are at a high risk of oropharyngeal gonorrhea, or they need to be aged 25 or above with a positive test result for oropharyngeal gonorrhea by NET in the previous 30 days. Men were randomized into either Listerine 0, which was the intervention group, or the biotin, which was the control group. In the in vitro study, biotin did not show any inhibitory effect against Neisseria gonorrhea. To maintain binding, we repackaged the mouthwash and also added the food dye to make both mouthwash look similar. So men were asked to rinse and gargle the mouthwash daily for 1 minute over the 12 weeks period. We've also provided an instruction sheet to the participant on how to use the mouthwash. It was a 12 weeks trial, which included clinic visit at week 0, week 6, and week 12. Participants were asked to provide saliva sample every 3 weeks At week 3 and week 9, we asked the participants to provide saliva by post, and week 6 and week 12, they were provided saliva at the clinic visit. Clinician-collected throat swabs were also collected at week 6 and week 12 during the clinic visit. At week 12, we also include a full STI screen. Here shows the flowchart of the trial. So we screened 786 men obsessed with men and recruited 530 men in trial, with 264 men assigned in the Barton group and 266 men in the Listerine group. We include men in the final analysis if they provide at least one specimen over the 12 weeks period. There was a total of 446 men provide at least one specimen over the 12 weeks period, which were included in the final analysis. The baseline characteristic was similar across the two mouthwash group. When we look at the oropharyngeal gonorrhea positivity, 4% in the Barton group compared to 7% in the Listerine group, but the differences was not significant. We also look at the bacterial load of oropharyngeal gonorrhea by specimen type from the swab and also saliva, but the bacterial load did not differ between the Barton group and the Listerine group. When we look at the secondary outcome, we find that urethral gonorrhea is the only outcome that was significant. There was 4.4% in the Barton group compared to 0.5% in the Listerine group, suggesting that men who used Listerine were less likely to have urethral gonorrhea. There was no significant differences in anal gonorrhea, chlamydia at any site, syphilis, and HIV. By looking at urethral gonorrhea, we compare men with urethral gonorrhea and also men without urethral gonorrhea but in trial. So the bar chart below shows clearly that men with urethral gonorrhea are more likely to use their saliva for insertive penile anal sex, more likely to engage in condomless insertive penile anal sex, and more likely to use the saliva as lubricant for masturbation compared to the rest of the men in the OMGEA trial. To conclude, this was the first RCT to assess the efficacy of mouthwash for preventing gonorrhea. Listerine did not reduce the incidence of oropharyngeal gonorrhea compared with Barton. Suggesting daily use of mouthwash is unlikely to prevent the acquisition of oropharyngeal gonorrhea. This may due to the different methods of using mouthwash. During the trial, we find that spraying mouthwash is more effective in reaching the posterior pharynx wall compared with gargling and rinsing. We also didn't specify the time for mouthwash use. It may be more effective closer to the time of exposure. There is a second similar RCT is currently underway in Belgium and asked men to use mouthwash before and after sex. There was also a moderate and significant reduction in secondary outcome of urethral gonorrhea in men who use Listerine compared with Barton. This may occur by chance, or possibly men may acquire their urethral gonorrhea infection from their own saliva. And that's the mechanism of action of Listerine was by reducing the load of Neisseria gonorrhea in the pharynx. There's so many people that I would like to acknowledge for the trial. And thank you very much.
Hi, my name is Stephen Sullivan, and I'm a project manager at the University of Michigan Center for Sexuality and Health Disparities. I'm presenting on at-home chlamydia and gonorrhea screening and remote video counseling among male couples on behalf of myself and Dr. Rob Stevenson. In the United States, gay, bisexual, and other men who have sex with men are at elevated risk for acquiring STIs relative to heterosexual men and women. Shown here are the site-specific median chlamydia and gonorrhea prevalence for MSM across 30 STI clinics within 10 US surveillance sites reported by the CDC in 2017. Between 2013 and 2017, the rate of chlamydia infection among men increased by 40%, which was largely attributed to rising incident infections among MSM. Additionally, between 2011 and 2016, the gonococcal isolate surveillance project found that MSM were significantly more likely to have antimicrobial resistant gonorrhea than heterosexual men. Improving routine screening among this population thereby is a key public health priority. Counter to past conceptualizations that posited casual sex partners were central to STI risk for MSM, recent modeling analyses has shown that 1 to 2/3 of new HIV infections among MSM were actually attributable to main partners. Although these findings are specific to HIV, they remain relevant for chlamydia and gonorrhea due to the high comorbidity of these STIs and similar routes of transmission. When MSM have sex with main partners, they're less likely to use barrier methods like condoms and have increased frequency of sexual encounters over a period of time. MSM with main partners have also been shown to screen less for STIs than their single counterparts. In this way, MSM couples may be at heightened risk for undiagnosed STIs like chlamydia and gonorrhea. To curb the STI epidemic, there have been calls to more efficiently deploy self-testing strategies among vulnerable populations. Home-based chlamydia and gonorrhea testing has been shown to increase screening uptake and achieve similar levels of treatment when compared to clinic-based testing. Self-collected chlamydia and gonorrhea samples have also been shown to have high sensitivity and specificity when compared to physician-collected samples. And lastly, at-home STI testing has been found to be highly acceptable across diverse populations. However, despite these benefits, no data exists on the feasibility and acceptability of at-home chlamydia and gonorrhea screening among MSM couples. To explore this, we launched a pilot study where we recruited 51 couples living in the United States. We provided each partner with a 3-site chlamydia and gonorrhea sample collection kit that were processed by a remote lab. And after testing, participants were given an online survey to complete individually and not in the presence of their partner. And lastly, we conducted 10 remote in-depth interviews via video call with 10 proposably sampled couples who completed the testing portion of the study. We structured the testing around 2 HIPAA-compliant video calls that partners could complete together or separately. The first was a pre-test instructional video call where study staff went over the informed consent document and asked participants to give verbal consent. The consent was acquired from both partners. Study staff went over the contents of the 3-site chlamydia and gonorrhea testing kit and explained how to use each element. This allowed partners to visually see how to conduct the throat swab, the rectal swab, and the urine sample, and ask clarifying questions along the way. Only one couple completed the pre-test video call separately from their partner due to scheduling conflicts, and the other 50 decided to complete it together. After completing the pre-test call, each couple was sent 2 chlamydia and gonorrhea sample collection kits to their home address via UPS, and couples were instructed that they could complete that sample collection with or without their partner being present. Of the 51 couples who were sent these kits, 49 returned samples to our lab partners to be processed. One couple reported feeling uncomfortable with sending biological samples once they received the kit in the mail, and the other was lost to follow-up upon the kits being delivered. After each partner's test results were ready and available from the lab, each partner was invited to complete a post-test video call where those results would be provided. They had the option of completing that call again together or separately from their partner, and all 49 couples decided to go ahead and complete that call in the presence of their partner. So during those calls, staff screen shared each partner's test results and then facilitated a conversation around sexual risk behavior, STI prevention, and screening and linkage to care if needed. So this is just a mock session, and that kind of shows what our provider background screens look like, and just to kind of get a glimpse of what a typical session would look like. For the pre-test calls, on average, they lasted 15 minutes in length with a minimum of 10 minutes and a maximum of 45 minutes. Only 4 out of those 51 video calls experienced loss of connection, and all of those were able to be reconnected after the first troubleshooting attempt. For the post-test calls, on average, they lasted 15 minutes with a minimum of 10 and a maximum of 25 minutes in length, and none of those 49 video calls experienced internet or platform connection issues. This is just a photo of our 3-site chlamydia and gonorrhea sample collection kit. As you can see, each sample collection material was provided a color-coded bag, one for the rectal swab, throat swab, and urine sample collection. These were prepared by our partners at Emory Center for AIDS Research. This is just some insight into the demographics of our 51 couples. As you can see here, the mean age was 30 years old, and they were predominantly white, college educated, and employed. So 49 couples or 98 individuals returned all 3 biological samples to be tested for chlamydia and gonorrhea. And of those 294 samples that we received, only 2 rectal swabs could not be screened due to poor quality or insufficient sample. We had 9 individuals test positive, and of those were primarily rectal cases as shown here. Study staff helped all 9 individuals who tested positive to find local sources of treatment in their area, and upon 14-day follow-up, all reported successfully obtaining antibiotic treatment. 1 participant followed up about their treatment status via email, and 8 completed the follow-up via phone call that on average lasted 5 minutes in length. For the 2 individuals who collected invalid rectal swabs, 1 was linked to local testing, and the other chose not to retest when given additional testing sites in their area. Presented here are some of our acceptability data from the post-test online survey that couples were instructed to take separately. Of the 49 couples eligible, we had 1 partner that was lost to follow-ups. Our sample here is 97. There was high willingness, as shown here, to retest using the self-collection materials, and also to retest at home. Participants also reported a high willingness to engage in telehealth services when receiving the results again. And lastly, they just reported an overall satisfaction with their experience testing for chlamydia and gonorrhea at home. For the remote qualitative interviews, we invited 5 couples where at least 1 partner received a positive test result, and 5 partners were both tested negative. We also recruited such that 10 out of the 20 participants identified as non-white. The interview guide was structured for dyadic interaction that centered on attitudes about how to use the sample collection materials and decisions they might while collecting the samples, and their experience accessing treatment for those who tested positive. Data were analyzed using a focus coding strategy and in vivo, and were also processed using thematic analysis. Presented here is one of our themes about how at-home testing fostered sexual communication among some couples. It's really, this was described as an opportunity to kind of reflect on the sexual agreement in the terms of their relationship to see whether or not it left them either protected or vulnerable to STIs like chlamydia and gonorrhea. Another theme we observed was how couples collaborated with one another during the sample collection process. So some conferred with each other about the sample collection instructions prior to collecting the samples to make sure that they understood everything and knew how to do everything properly. Others reminded each other to complete the sample collection process and also coordinated with one another about the shipment and return and packaging of the samples. And as shown here, some even assisted their partners in the sample collection by swabbing their throat and the rectum for them. I think this just kind of showcases the variety of ways that partners actually helped one another test at home and also make sure that their samples could be high quality as well. Another theme we noted was a misunderstanding around what it means to be fully negative for chlamydia and gonorrhea. Essentially, some participants described believing that if one area of their body was tested and found to be negative, that all areas could be assumed to lack infection as well. I think this particularly became relevant for us as we were trying to understand maybe some confusion or perhaps misunderstanding around why a 3-site chlamydia and gonorrhea test would be worthwhile or warranted in the at-home context. And I think, it was perhaps interesting for providers to explore as well, for people to really kind of fully embrace this service. So overall, we found high acceptability and satisfaction among our sample of MSM couples to test at home for chlamydia and gonorrhea. We had less than 1% of our samples be rejected due to poor quality, which may also speak to the ways in which couples helped one another through the sample collection process at home. We're also encouraged by the way that couples, engaged with their test results in a dyadic fashion that reflected on the terms of their sexual agreement in relation to STI prevention and testing. And lastly, the misconception about the site-specific nature of chlamydia and gonorrhea may be important to address for 3-site chlamydia and gonorrhea tests to be seen as warranted by these communities. So thank you. I'm going to go ahead and stop there, and I'm happy to answer any questions.
Good morning. My name is Winston Abara, and I am an epidemiologist with the Division of STD Prevention at the United States Centers for Disease Control and Prevention. The title of my presentation today is Case Control Study to Evaluate the Effectiveness of a Serogroup B outer membrane vesicle meningococcal vaccine against gonorrhea, New York City and Philadelphia, 2016 to 2018. Gonorrhea is the second most commonly nationally notifiable disease in the United States. In 2018, approximately 583,000 cases of gonorrhea were reported. Since historic low rates in 2009, the rate of reported gonorrhea cases has increased by about 80%. Effective antibiotic treatment is crucial to the prevention and control of gonorrhea. The Centers for Disease Control and Prevention currently recommends 250 milligrams of intramuscular ceftriaxone and 1 gram of oral azithromycin for the treatment of uncomplicated gonorrhea. Gonorrhea treatment is, however, complicated by the ease with which Neisseria gonorrhea develops antimicrobial resistance. Neisseria gonorrhea has developed resistance to every first-line antimicrobial treatment since the 1930s. Reports of declining susceptibility to cephalosporins and azithromycin have raised concerns about the threat of untreatable gonorrhea in the future. New approaches, such as vaccination, are needed as a long-term strategy to prevent gonorrhea. There is currently no licensed vaccine against gonorrhea, and previous attempts to develop one were unsuccessful. Some studies have demonstrated that outer membrane vesicle serogroup B meningococcal vaccines may be protective against gonorrhea. Ecological studies from Cuba, Norway, and Quebec showed a decline in the rate of gonorrhea cases following OMGEA mass vaccination campaigns. A retrospective case control study from New Zealand found that the locally developed OMGEA vaccine was 31% effective against gonorrhea. The cross-protection of OMGEA vaccines may be attributed to the high level of genetic similarities between Neisseria meningitidis and Neisseria gonorrhea. There are currently 2 licensed MenB vaccines in the United States. Bexsero, also known as MenB4C, is a multi-component OMGEA vaccine. It was approved for use in the US in 2015. It contains 3 recombinant proteins and 1 OMG antigenic component, and is administered in 2 doses separated by at least 1 month. Trumemba, also known as MenB FHBP, is not an OMG vaccine. It was approved for use in the US in 2014 and can be administered as a 2-dose vaccine or a 3-dose vaccine. The Advisory Committee on Immunization Practices currently recommends MenB vaccination in 16 to 23-year-old persons. So given the high rates of reported gonorrhea cases and research studies that have shown that MenB vaccines may be protective against gonorrhea, the objective of this analysis was to assess if the receipt of MenB4C is associated with a lower likelihood of gonorrhea diagnosis compared to chlamydia diagnosis among young persons aged 16 to 23 years old who were diagnosed with gonorrhea or chlamydia during January 1, 2016 to December 31, 2018. So using a retrospective case control study design, we identified gonorrhea and chlamydia monoinfections diagnosed among 16 to 23-year-old persons from the STI surveillance records of the New York City Department of Health and Mental Hygiene and the Philadelphia Department of Public Health. We linked records of gonorrhea and chlamydia monoinfections to the immunization registry records to determine MenB4C vaccination data. We also obtained sociodemographic data of eligible persons with gonorrhea or chlamydia monoinfection. Sociodemographic data were obtained at the person level, and data for gonorrhea and chlamydia monoinfections were obtained at the case level. We classified gonorrhea monoinfections as cases and chlamydia monoinfections as controls. We selected chlamydia monoinfections as controls because this minimizes bias due to screening practices, and persons with a chlamydia diagnosis are likely to have similar epidemiological and risk characteristics as persons with a gonorrhea diagnosis. We classified gonorrhea monoinfection as an infection when Neisseria gonorrhea is detected and Chlamydia trachomatis is not. We also classified chlamydia monoinfection as an infection where Chlamydia trachomatis is detected and Neisseria gonorrhea is not. We defined vaccination as receipt of 2 doses of MenB4C separated by 30 to 180 days. We considered cases and controls exposed to the vaccine if the infection was diagnosed at least 30 days after receipt of the second dose of the vaccine. The ACIP recommends 2 doses of MenB4C separated by at least 1 month. The recommendation does not have an upper limit of the time between doses. However, studies have shown that 2 doses separated by 30 to 180 days provide sufficient seroprotective titers against serogroup B meningococci. Because seroprotective titers can be detected 30 days after the second dose, we considered cases and controls exposed to MenB4C if the gonorrhea or chlamydia monoinfection occurred at least 30 days after the date of administration of the second vaccine dose. We used date of gonorrhea and chlamydia specimen collection as a proxy for date of diagnosis. We defined duration of vaccine-induced immunity as 6 months. We conducted frequencies and descriptive characteristics to describe the sample. We calculated unadjusted and adjusted prevalence ratios and 95% confidence intervals using log binomial regression with generalized estimating equations to account for correlations between multiple infection episodes per patient. We included covariates that were significant in bivariate analysis and empirical correlates of gonorrhea and chlamydia in the multivariable model. So the multivariable model included MenB4C vaccination status, gender, race, and jurisdiction. We calculated vaccine effectiveness as 1 minus adjusted prevalence ratio. Statistical significance was set at less than or equal to 0.05. The institutional review boards of the Centers for Disease Control and Prevention, New York City Department of Health and Mental Hygiene, and the Philadelphia Department of Public Health reviewed this project and determined this project was non-research and therefore exempt from further review. So here I present the results. This slide shows the sociodemographic characteristics of the persons included in the analysis. Pertinent findings are highlighted in the red box. Among persons with non-missing data, majority of persons with a diagnosis of gonorrhea or chlamydia were Black, female, non-Hispanic, and eligible for the Vaccines for Children program. This slide shows MenB vaccination and STI characteristics. The majority of persons did not receive any MenB vaccine. Among persons who received at least 1 dose of any MenB vaccine, the majority received MenB4C. Among persons who received at least 1 dose of MenB4C, 47% received 2 or more doses. Chlamydia accounted for the majority of STI cases. So here I show the results of the bivariate analysis. Significant associations are highlighted in the red box. Vaccinated persons were less likely to be diagnosed with gonorrhea compared to unvaccinated persons. The unadjusted prevalence ratio was 0.58, with a 95% confidence interval of 0.48 to 0.71. Males were more likely to be diagnosed with gonorrhea compared to females, and persons of Hispanic ethnicity were less likely to be diagnosed with gonorrhea compared to non-Hispanic persons. On this slide, persons from New York City were less likely to be gonorrhea cases than persons from Philadelphia. No other significant bivariate associations were observed. This slide shows the multivariable model of factors associated with gonorrhea diagnosis. Vaccinated persons were less likely to be gonorrhea cases than unvaccinated persons, with an adjusted prevalence ratio of 0.59, suggesting that the effectiveness of MenB4C against gonorrhea is 41%. So there are limitations to this study. The study findings can't necessarily be generalized because the data were obtained from 16 to 23-year-old persons with a gonorrhea or chlamydia diagnosis in New York City or Philadelphia. We did not have data on anatomic site of infection, and so we were unable to assess vaccine efficacy by anatomic site. There is variability among gonococcal strains. We did not have gonococcal strain data, and so we were unable to assess if vaccine efficacy varies by gonococcal strains. Misclassification bias is another limitation of this analysis. We used date of specimen collection as date of diagnosis and determined exposure to the vaccine if the specimen collection date occurred after the vaccination date. Because gonorrhea and chlamydia can be asymptomatic, it is possible that some infections could have occurred before vaccination but detected after vaccination. In this scenario, these infections will be misclassified as exposed to the vaccine when they were not. Reporting bias is another limitation. This analysis was based on cases reported to New York City and Philadelphia. It is possible that not all gonorrhea and chlamydia cases were reported. So reporting bias may be a limitation if characteristics of cases reported to the jurisdictions differ from cases that were not reported. We did not have data on information of sex partners, and so we can't make conclusions about vaccine effectiveness among men who have sex with men who have sex with women only, or women who have sex with women only. So in conclusion, these findings show that men B4C may confer cross-protection against gonorrhea. They also demonstrate that it is feasible to develop an effective gonococcal vaccine. Clinical trials to examine the efficacy and immunogenicity of men B4C are needed. These trials are essential to evaluate men B4C vaccine efficacy by anatomical site and in the setting of co-infections such as chlamydia and HIV. They are also important to understanding the serological correlates and mechanism of antigonococcal immunity. There is an ongoing trial that is examining the protective effect of men B4C against genital and extragenital gonorrhea. Another ongoing trial is assessing gonorrhea immune response after men B4C vaccination. Findings from these clinical trials are critical to informing our understanding of men B4C induced antigonococcal immunity and optimizing the public health benefits of a future gonococcal vaccine. So I'd like to acknowledge my co-authors from the CDC, the Philadelphia Department of Health, and the New York City Department of Health and Mental Hygiene. Thank you for your time.
Hello and welcome. My name is Chrysovalantis Staphylis, and I'm an assistant project scientist at UCLA. I'll be presenting the results from a pilot study evaluating Cefixime for treatment of early syphilis. I would like to thank you for your interest in this presentation, and I hope that you find it interesting. Let's start. During the past years, syphilis and congenital syphilis rates have been increasing. Our efforts for treatment and prevention are complicated by shortages of penicillin, which is the standard of care treatment. In this recent study from the WHO, 39 countries reported significant shortages of penicillin. Benzathine penicillin G is the most effective treatment. There are a few alternative treatment regimens, but there are limitations to their use. For example, doxycycline is contraindicated in pregnancy and in children. Ceftriaxone, on the other hand, requires multiple injections for 10 to 14 days. So there is a need to identify more antibiotics that could be used in clinical practice for syphilis. We decided to evaluate Cefixime, and here are a couple of reasons. Cefixime is a third-generation oral cephalosporin. It has a broad antibacterial spectrum similar to that of ceftriaxone. The low MIC of Treponema pallidum to cephalosporins such as ceftriaxone makes cephalosporins candidates for evaluation. In addition, Cefixime has a favorable pharmacokinetic profile, as a single dose of 400 milligrams by mouth can yield a maximum concentration of 4.8 microgram per ml in 4 hours. The half-life of Cefixime is also 4.2 hours. There are also a few additional practical reasons. Cefixime is administered orally, which eliminates the need for multiple painful injections. It is also considered an essential medicine by the WHO, and it is FDA approved. Finally, Cefixime is already used for other bacterial infections. So the familiarity of clinicians with using Cefixime, as well as the already known safety profile, could make it easier and faster for clinicians and health systems to adopt a new treatment. In order to evaluate the efficacy of Cefixime, we designed a non-comparative randomized study. Enrolled participants were randomly assigned to receive either Cefixime 400 mg by mouth 2 times a day for 10 days, or receive the standard of care injection of penicillin G. We monitored the RPR titers for serological response to treatment. Treatment success was defined as a 4-fold or greater decrease at 3 or 6 months after treatment. We enrolled adults diagnosed with early syphilis and with an RPR titer 1 to 8 or higher. HIV-infected individuals had to have a CD4 T cell count of 350 cells per cubic millimeter or higher and viral load of 200 copies per ml or lower during the 6 months before enrollment. Finally, participants had to be able to return to the clinic for follow-ups and be available for contact. We excluded pregnant women, individuals with high serofast RPR titers, individuals who received other antibiotics, reported allergies, or may have a condition that would affect their capacity to participate. We enrolled participants from primary healthcare clinics of the AIDS Healthcare Foundation in Los Angeles and Oakland, California. After enrollment, participants were required to return to the clinic 3, 6, and 12 months after enrollment for clinical evaluation and laboratory testing. Our team would also call participants of the Cefixime arm 10 days after enrollment to record treatment completion. Overall, 58 participants were enrolled, 27 in the Cefixime arm and 31 in the penicillin arm. The majority of the participants were Hispanic or Latinx. The majority of the cases were classified as early latent cases of syphilis. And finally, almost all the participants were HIV infected. We analyzed the data for their per-protocol and intention to treat populations. For their per-protocol population includes participants who fulfilled the enrollment inclusion criteria, had no protocol deviations during the study, and attended baseline 3 and 6 month visits. On the other hand, the intention to treat population includes all the enrolled participants regardless of deviations, loss to follow-up, or withdrawals. 12 participants were included in the per-protocol analysis. The success ratio was 10 out of 12 Cefixime participants, or 83%. 27 participants were included in the intention to treat analysis, with a success ratio of 14 out of 27, or 52%. Similarly, we conducted the same analysis on the participants of the penicillin arm. 16 participants were included in the per-protocol analysis. The success ratio was 15 out of 16 participants, or 94%. In the intention to treat analysis, 31 participants were included, with a success ratio of 25 out of 31, or 81%. We present here the cases that were classified as treatment failures during our analysis. A treatment failure was defined as a case that the RPR titer between baseline and 3 or 6 month visit increased or did not decrease by 4-fold or greater. Cases with missing evaluable data at 3 or 6 months, such as withdrawals and loss to follow-up cases, were not included in the per-protocol analysis. In the intention to treat analysis, these cases were characterized as treatment failures. Protocol deviations were included in the intention to treat analysis and showed a 2-fold decrease. Only the group of serological failures that includes participants that fulfilled all the study eligibility criteria was included in the per-protocol analysis and includes 3 cases with a 2-fold decrease. In conclusion, in the per-protocol analysis, 10 out of 12 participants were successfully treated with Cefixime, showing that Cefixime could be a potentially efficacious treatment. However, when interpreting the results, it is important to remember a few things. The small sample size of the study, which affects the precision of our estimates, and the fact that the study was not designed to detect a difference between penicillin and Cefixime. Regardless, the initial results are encouraging, and large trials on different populations are the next step. As a matter of fact, 2 studies are currently evaluating Cefixime for treatment of syphilis. First, a WHO-led trial in Brazil that evaluates Cefixime 400 mg in non-pregnant women. The protocol of the study was recently published and it is available online. The second study will be conducted by our team. We received an NIH grant to conduct a non-inferiority trial comparing Cefixime 400 mg to penicillin G. The study protocol and procedures are currently under development and enrollment is projected to start on January 2021. Before closing, I would like to thank the patients of the clinics who volunteered to participate in the study. I would also like to acknowledge that we received a research grant from the AIDS Healthcare Foundation to conduct the study. Finally, this study wouldn't be feasible without the efforts of all the team members. Our team from UCLA, led by Dr. Klausner, and the research assistants Corey Keith, Shivani Mehta, and Ashwarya Wright. Our team from the AIDS Healthcare Foundation, led by Dr. Telalian, included also Drs. Milner, Purian, Okada, as well as Mr. Mejia. This is the end of my presentation. I'll be looking forward to your questions. You may submit them during the live Q&A session on September 23rd. If you wish to contact us, please use the on-screen email addresses. Thank you for watching my participation.
Hi, my name is Meena Ramchandani, and I'd like to thank the conference organizers for letting me present an oral abstract titled "A Demedicalized Model of PrEP Follow-Up Facilitates High-Volume PrEP Provision in a Sexual Health Clinic." So sexual health clinics see a large number of patients with indications for PrEP. PrEP, or pre-exposure HIV prophylaxis, is incredibly important for the prevention of HIV, but it does have the potential to tax clinic capacity. There's frequent follow-up visits, STD testing is needed, and then counseling and monitoring that might be difficult to integrate into clinical care. So we'd like to share a model that relies on DIS, or disease intervention specialists, within a sexual health clinic who can help with routine follow-up for PrEP patients. This, along with self-STD testing, has the potential to reduce the extra clinician time that's needed, and then for the patients, decrease barriers to obtain quick and efficient PrEP care. In our model, patients see DIS 1 month after PrEP initiation and then every 3 months. Patients see a medical provider at the initial visit and then at least once annually, but also on an as-needed basis. Over time, this is how our PrEP program in the sexual health clinic has evolved. It initially started in the late 2014 with 1 DIS and 1 clinician, but then it quickly expanded to include 2 DIS, and then all the clinicians of the clinic helped to initiate patients on PrEP and then do follow-up medical visits. Our eligibility criteria expanded over time to include more opportunities for patients to get on PrEP, and the referrals came from patients who were just coming into the sexual health clinic, for example, to treat an STD, or from partner services. And then when our program was analyzed at the end of 2019, there were a total of about 1,300 patients who had attended an initial PrEP visit overall since the beginning of the program. In December of 2019, there were 750 patients with active prescriptions at that time. Now, in this program, the DIS communicate frequently with patients via WellTel, which is a text messaging system for outreach and communication. The patients really like it because it has direct and easy access to someone that they can get in contact quickly with. And then there were different programs that paid for PrEP. So PrEP-DAP is Washington State's Drug Assistance Program. Apple Health is Washington State's Medicaid. And then there's also the Gilead Assistance Program. And eventually, medical visits and lab costs were paid for by PrEP-DAP in 2018. DIS helped with insurance, with paperwork, with outreach, with counseling, and then really making sure patients actually picked up prescriptions soon after their initial visit and HIV testing. So this is the criteria, this is the current criteria to start PrEP in the clinic. And these patients we have found demonstrated the highest risk of acquiring HIV based on region epidemiology. I won't go too much in detail, but this has evolved to increase the number of patients on PrEP and eligible for our PrEP program over time. For the analysis of this program, we looked at PrEP patients attending an initial visit from late 2014 to late 2019, and then the PrEP retention analysis included follow-up through February of 2020. A Cox proportional hazards regression was used to identify factors associated with PrEP discontinuation. This table shows the demographic of our PrEP clients. As you can see here, most were in their 20 to 40 age range. Most were MSM. 55% were white, 10% were Black, and 26% identified as Hispanic or Latinx. 30% were uninsured, and 11% had used methamphetamine in the last year. Of all those who had enrolled in the program, 734 clients had a bacterial STI in the 3 months prior to initial PrEP visit. And as you can see from this bar graph, 170 had multiple STIs in the 3 months prior to their initial PrEP visit. Now, one of the eligibility criteria to enroll in the PrEP program is, for example, an MSM diagnosed with syphilis or rectal or urethral gonorrhea, which is one of the reasons for these high numbers. But what this also shows is that the sexual health clinic who sees patients with these bacterial STDs is a great place to incorporate a PrEP program, as there has been evidence to suggest that, for example, patients with rectal gonorrhea or with syphilis are at higher risk of acquiring HIV in the next year. We were able to analyze the referral source for PrEP clients within our health clinic since 2015, and 50% of the PrEP clients who had been referred were patients of the STD clinic. For example, those patients seen for STD testing or for treatment. 3% of the referrals came from partner services, although I suspect this number is higher, and there's quite a few patients where the referral source data was missing. So this graph depicts the PrEP enrollees and active prescriptions in the sexual health clinic over time. On the left, on this y-axis, is the number of cumulative enrollees and prescriptions, which are depicted in both blue and green lines. So in blue, you can see the number of cumulative enrollees that have increased over time. And then in green is the number of active prescriptions that have subsequently increased as the number of enrollees have increased. On the right, the y-axis shows the number of new enrollees over time. And the average number of patients initiating PrEP each quarter increased from about 20 in 2014 to about 88 in 2019. There was this huge, large jump in quarterly initiations in 2017, and that was concurrent with a policy change integrating PrEP initiation into walk-in visits with all the medical providers instead of just one medical provider, and having most of the follow-up done by DIS. And over time, as I mentioned, there was an expanding eligibility criteria as well. We found that 23% of clients discontinued PrEP within 3 months of initiation, and the median duration of PrEP use was about 9 months. On multivariate analysis, PrEP discontinuation was significantly associated with 3 different variables: younger age, Black race, and methamphetamine use. These are the rates of bacterial STIs while on PrEP, and the incidence of chlamydia, gonorrhea, and syphilis infection among our PrEP clients was 95, 91, and 16 cases per 100 person years, respectively. So the rates of bacterial STIs remain high in this group, advocating the need for quarterly STD testing in these patients and integration of STI care within PrEP clinics. So over this time period of about 5 years, there were 13 new cases of HIV, about 2 to 3 per year. All those with new HIV diagnosis did link to care within 1 to 2 weeks and started antiretroviral therapy. Most actually linked less than a week, so very quickly. And with regards to the new cases of HIV, 5 were actually diagnosed at their initial PrEP visit. So they were being seen by a clinician for PrEP, and their HIV labs demonstrated they actually had HIV, or within 1 week. 7 patients had poor compliance or just self-discontinued PrEP. They had adverse effects or perceived reduced risk, and so they just stopped PrEP. And when they showed up for regular testing, they were found to have HIV. This column here denotes the number of patients with HIV-resistant strains that were found when labs were taken, and these are the resistance types that their strains demonstrated. So in conclusion, I think a demedicalized model of PrEP follow-up integrated within a sexual health clinic facilitates PrEP provision to a large number of persons without HIV who might benefit from this medication. Sexual health clinics can identify, find, and engage large groups of individuals at risk for HIV, and it kind of provides this one-stop shop. It helps to allow it connects clinicians who feel comfortable prescribing PrEP with patients who would most benefit from PrEP. Patients can see a clinician, enroll in PrEP, deal with insurance issues and paperwork, and then start PrEP and get routine follow-up care. DIS have immense expert in communication, interviewing, and counseling, and then it also helps to integrate STI screening and management within PrEP care as part of a patient's overall sexual health. I will say in the real world setting, a new HIV diagnosis does occur and patients can get resistant strains. So it's really important to monitor, for example, if patients have like a very long delay in starting PrEP from their initial visit, they have missed pills, and then really talking to patients about what they think their risk of is acquiring HIV and a perceived reduced risk for acquiring HIV. And then also implementing some way to contact patients and link them to HIV care in an expeditious way and start ARVs if needed. So I'd like to thank the many people on this list who have been amazing and wonderful and really helped to make this program a success, as well as analysis of the data. Here is my contact information, and thank you for listening.